Mm.
You are looking round, madam, but it's okay. The class has started. Okay, so guys, we are live, and I think Dr. Shilpa has also she left.
Yeah, no,
No,
I'm here.
she's
I'm
back.
sorry.
Yeah.
Yeah,
So start.
yeah. Good evening, everyone. So today's topic for the class is difficult embryo transfer. So as we all know, that embryo transfer is the rate limiting determining the success rate of the IVF, and hence it becomes very important to make it smooth and also increase the fineness of our procedure so that the patient gets the best of the results. But sometimes what happens, unfortunately, it is not as easy as it seems. So we get stuck in this step, and for which we will get some tips today by Dr. Jay. This will be a practical class without much of theory in it. I will show a video of difficult embryo transfer at the end. Yeah, you can take over, please.
Okay. So hi guys, I'll straight switch to the screen sharing. And it is important that we understand that whenever we are trying to talk of embryo transfers, okay, what should we keep in mind predominantly? Okay, so we have a uterus which is like this, which is present. The reason I'm drawing a uterus like this because it is normally a mid-positioned uterus. Okay, and you are going to have a partially filled up bladder over that. This the most important thing about this bladder is that keep it partially filled only. Many a times you will have a bladder which is going very high up and the uterus is a very tiny uterus behind. So what it does is it can cause some amount of acute retroflexion to that uterus. So that is something which is to be avoided. It's the most important thing in a difficult embryo transfer for any human being is to basically avoid it. Okay, it becomes difficult when you make it difficult. So you just follow the rules. So you keep it mid flexed, the uterus size, and you keep a half filled bladder. Okay, that is something which is very, very important. Don't keep an empty bladder because you are going to change the angle and make it acutely anti flexed as well. Obviously, I know that there are certain situations where the uterus is already retroflexed. So people love to do embryo transfers in patients who are with grade 4, grade 5 endometriosis. Everything is stuck. Surgery has been abandoned twice. No ovary is seen. But people don't want to get operated because somebody has said that in that situation, doing IVF is a much better option. So actually, IVF doing is a much better option if you are doing self cycle. Okay, and if there is no ovarian cyst, but if there is something like that, like a frozen pelvis, to convert your difficult embryo transfer to an easy embryo transfer, all you need to do is something called as laparoscopic surgery, which is the scientific guideline also. The dual laparoscopic surgery, correct the anatomy and then put these embryos inside. That will reduce the uterine contractility also and make your process slightly successful also. But let's assume you did not do that. All right. A lot of times people have this wrong habit. Okay, I will just expand the cervical canal a little for all of us. So let's assume this is the cervix which we see. Okay, I will just draw the cervix for all of you. That is the cervical canal. This is the cervix, and we have the uterus above that. It is the cervical canal which ends inside the endometrium. We have an outer catheter and we have an inner catheter. So we have this outer catheter which goes here till the internal os. Okay. And through that, we have the inner catheter. See, the thing which is very, very important is if you study the outer catheter itself has a little bit of an angle like this. The outer catheter itself is a bulb like this. It has an angle which is pointing antivertedly. The reason why it is pointing upwards is because in cases of mild retroflexion, you can retrovert the same angle by just rotating the catheter and it becomes something like this. So your embryo transfer for the minimal rotation, this rotation which is present inside is going to be approximately 10 degrees. So for something which is rotated inside the uterus, okay, by approximately 20 degrees, it is going to be fine. The problem comes when the rotation is more than 20 degrees. This is something which you have to keep in mind. So the best way to actually correct this slightly further, okay, especially in cases of anteversion, okay, is to actually give the patient a head low. You give a nice steep head load to the patient while doing the embryo transfer, automatically the uterus will slightly get retroverted, and even in acute antiversion, the antiversion will come to 20 degrees and your embryo transfer will become very, very easy. That is one thing. Second, I also want to point out something important which people often don't realize about the cervical canal. So I will draw the cervical canal one time more. See, there are many a times where you will have a cervical canal which is something like this. See, correct? All of you have seen this. There is a cervical canal which is something like this, which is a bent cervical canal. So remember one thing. Okay, if there is a single arc which is bent, okay, there is no problem. There is no problem in this at all. You can easily navigate, because see, there the catheter will go like this, rotate it, it will go like this, and then push it inside, it will go. It is not like it is supposed to cross a bridge. It is a very small distance. The distance from here to here is just 4 centimeters otherwise. So it is very easy for a 4 centimeter bridge to be crossed. Okay. Sometimes what is going to happen is that you are going to reach the catheter till here. Okay. But it is going to have one more bend. This cervical canal is going to have one more bend. I'll tell you, I'll just draw it for you and show you. I'll draw the outer cervix. Sometimes it is like this. Of course, this could be in multiple angles. I am just drawing it in one angle to show it to you. But remember one thing, whenever you have more than 2 angulations, this is angulation number 1, this is angulation number 2. Whenever you have more than 2 angulations which is present inside the cervix, one, it is not common. So it is a rare problem. You don't see it in every patient. Probably you are going to see it in 1 in 40 or 1 in 50 patients. Now, whenever you have something like that, what typically happens is there is going to be blood which is going to start to form at the tip of this catheter. There will be blood which is going to be formed here. In order to avoid this, the best thing is to do a hysteroscopy. Okay, always remember this. Whenever there are more than 2 angulations, do a hysteroscopy, correct it. In the hysteroscopy, 99% of the people do this mistake, that they do something called as dilatation. Do not dilate it. It is not the right thing. Put your hysteroscope inside and cut these angulations. You can use your Collins knife to cut these angulations. There are many people who do not understand anything, and they say that if you cut this, you are going to risk preterm labor and the cervix is going to become incompetent. My dear friends, it is going to become incompetent when you damage something called as the internal os. You are almost never going to go and damage the internal os in these type of situations. Damaging this part of the canal does not lead to any form of incompetence. So please remove that thing from your head. It is definitely not going to happen. If in case you remember these rules, then your difficult embryo transfer will become easy. Is there a role of mock ET? Now, please let me be clear. I don't do it. But I know a lot of people do it. Okay. So I think if you are used to doing mock ETs, please do mock ETs. If you are not used to doing mock ETs, don't start doing mock ETs thinking that it is going to enhance your success rates. Okay. I think one of the best things to do in order to probably understand if an embryo transfer is easy or it is going to be difficult is simply look at the cervix. Whenever you are examining this patient, just look at the cervix. The cervix which is bent, the cervix which is crooked is going to be visible. It is not going to be an invisible thing. Often people are going to complain about this thing, that I had a patient who had stenosis of the cervix. They had stenosis of the cervix at the internal os. Then the next question we ask the doctor, was she in menses? I mean, does she have menstruation? Then the loud answer is, of course, yes, she is having menstruation. If she is having menstruation, you can't have a cervical stenosis. Okay, that is not possible. Cervical stenosis is going to cause hematometra. Okay, it is a Mullerian anomaly. So basically what could have happened is it could have been a pinpoint internal os. Pinpoint internal os is common. Again, the best method, if in case you think it is a stenosed cervix or if it is a pinpoint internal os, the best method is to use a simple office hysteroscope. It will dilate the cervix to more than 3 millimeters, and then passing through 3 millimeters is going to be very, very, very easy. So not at all, one should not at all worry, okay, in that type of situation. Okay, now there could be certain people who will say that, whenever I am having a difficult embryo transfer, I like to use atosiban. See, practically it has got no major role. Okay, I like to give a painkiller to reduce this. It has got no major role. I like to hold the lip of the cervix. You can, but the problem of holding the lip of the cervix is it does not really aid in that much angulation. Really, the best way, in my humble opinion, is to just give a head low. If it is required, holding the cervix is not recommended. It may stimulate uterine contractions. Okay. Apart from this, okay, do not make the confusion, because loading the embryos is also a very, very important technique. If you are not doing it on your own, then I strongly recommend all the people who are watching this episode to start learning to load to how to load these embryos on your own and put the embryo transfer catheter inside, because that is something which is very critical. I know a lot of people are big time followers of using ultrasound guided embryo transfer. That's a great thing if you are using it that way. I'm not very used to it, but I think it is a great thing. Okay, I don't do an ultrasound guided embryo transfer for every patient because I'm not used to it, but I think it is a great thing. If you are using it, and if it is a part of your practice, then please continue to do that. Apart from this, apart from all the things which we encounter, one thing I wanted to tell you, there are some people who will say that I use a hard stillet, basically, which is available in the embryo transfer catheters. See, the thing with hard stillet, it is very good, but remember one thing: when you use a hard stillet, don't go beyond the internal os, because the hard stillet will damage the endometrium inside, and if it damages the endometrium inside, it can cause bleeding, and that bleeding is going to interfere with implantation much more, much more, okay, than the blood of your soft outer transfer catheter. Keep that in mind. I am not somebody who has done anything like intra transmyometrial embryo transfer. I am not somebody who has ended up doing things like transfallopian embryo transfer and all that shit. Okay. So I don't believe in all those things at all. Okay. I think at max, if you are little retarded, you can try something like a transmyometrial embryo transfer once in 5 years for something which is very bad. Because I am talking to you from experience of women where we have done embryo transfers in women who have undergone cervical, uterovaginal anastomosis for cervical agenesis. Okay, it works very well. One need not really worry or take so much tension in those types of things. Those are tough cases, but it still works very well in all of them. Now, one more thing can cause a very difficult embryo transfer, and that is doing embryo transfer in patients who have Mullerian anomalies. Okay, these are patients in whom it is recommended that you should do an embryo transfer under general anesthesia, because the length of the vagina or the breadth of the vagina which is present may or may not be adequate enough for you to pass a cusco speculum to it. Okay, that could be a small issue. So just keep that in mind. Whenever you are doing something like this, it is better to give general anesthesia. If you give general anesthesia, okay, your pinpoint cervix, internal os, stenosis, all that will disappear any which ways, because many a times this cervical stenosis and all these types of things are somewhat also related to the anxiety of the patient. So if the anxiety of the patient goes down, okay, they are in general anesthesia, all these things will disappear any which ways. Okay, so with that much, I think this covers almost everything as far as difficult embryo transfers is concerned. And maybe one or two questions from Dr. Shilpa GB.
Yeah, in endometriosis, do you see that there is any more difficulty in doing the transfers, especially?
Yeah, if it is not corrected, then yes, there is a difficulty.
No, even after correction, do you think, I mean,
No.
And the
See, I'll
revision
tell
of
you one thing. Almost after any form of laparoscopic surgery, the difficulty goes away. Why? Because in laparoscopic surgery, even after you correct everything and you are doing IVF, no, our routine khujli is to test the fallopian tubes. Okay. If you want to test the fallopian tubes, automatically to pass methylene blue, you will cause some amount of dilatation of that cervix. And that dilatation of the cervix stays for the next 3-4 months before it gets re-stenosed. So any form of laparoscopy done in fertility patients actually improvises this outcomes on its own only.
Okay, what's your thought on the revision of the cervix? I mean, is that what you told just now in the beginning,
Yeah,
that
yeah,
the angulation part
yeah,
of it?
yeah. Better to
Okay,
cut it, madam.
so okay, and you cut it with scissors, you said. Do
No,
you
no,
want to
Collins
use
knife, I said.
Collins? Yeah, yeah, Collins knife. For cases like this, I mean, is using Hyosemax or Piroxicam, do you think it helps in any way?
No, madam.
Not really. Okay, and you don't do a mock transfer, and if in
I
case if
don't do
you,
it, but as I said, if people like to do it, then they should continue to do it.
yeah, but I think it is 50% of them don't do it at all. So if at all, if they are not doing, and if they find it difficult to do the transfer, and if they are not able to
Refreeze.
negotiate, so can we do the refreeze?
Of course.
Yeah. So what would be the recovery of those embryos after refreezing?
Or a beautiful.
Okay. Uh, So under anesthesia, you don't do it routinely except in Mullerian anomaly
Yeah.
cases, you said. Also, the steroid usage, you said it you don't use it very often, and
No.
majority of the cases you manage with head low.
Yeah.
Okay, yeah, I think we are done. So blood on the tip of the outer sheath doesn't really matter. And what about in adenomyosis cases where it will be difficult to, I mean, locate the endometrium and anyway, you don't do it under ultrasound guidance. Uh, but if at all in adenomyosis, what would be the challenge you think?
I think one of the challenges in adenomyosis is not location, it is the length of that internal, the length of that shaft which goes inside the cervix. Because many a times in adenomyotic uterus, no, it is that endometrium is placed on the anterior end. So what typically happens is where to deposit the embryo is a big challenge, madam.
Yeah,
In
yeah.
that situation, your inner catheter will go a little deeper as
Mm,
compared to the outer catheter in adenomyosis.
yeah, yeah. Yeah, I think so. But don't you think like ultrasound improves the success rate of embryo transfers?
I don't know. Must be
Mhm.
improving.
Okay, so you do office hysteroscopy, and in that you can negotiate it. But when you actually do the embryo transfers, you find it a little tough to negotiate. So do you make it a point to write down in every file that, I mean, this is the direction of the cervix, like how people actually do it? Do you think it makes sense?
That will make sense if somebody who is doing histoscopy is different than the person who is doing embryo transfer.
Okay, okay. And if it is angulated in a particular direction, say like a left or a right, deviated and all that.
One
Uh,
angulation, the catheter will negotiate.
hmm, hmm,
Two
hmm, hmm.
angulations means there is going to be blood on the outer catheter.
Yeah, yeah. Okay. So in
No,
that,
Indrani madam, we don't do office histoscopy in all cases. We don't do.
okay.
And
Yeah.
the beauty about office histoscopy is sometimes office histoscopy is much more tougher to do because it is a rigid scope. So what typically happens with the rigid scope, and if somebody is a novice, 50% of that 50% kya zyada 2 minutes will go in locating where the cervix is. Forget entering the uterus. Okay, they will be in the vagina only and dreaming about the os. Then they will be wondering, acha cervix kidhar tha. So in that office hysteroscopy, you need to be actually office hysteroscopy. If at all you want to do, somebody very good should do it. Okay, because they can put the office hysteroscope till the ostia in 1 minute. If you see a newcomer doing it, no, huge problems will happen.
Okay. Yeah. In previous cesareans, if there is fixed uterus and all, so
That's
do
very
you?
easy, no. You will put the cuscos and you will not see the cervix only. So you will have to order a larger size cuscos, no, that big one. Then only you will see the cervix. But
Yeah,
once you see the cervix, entry is very easy, madam.
I know, I know. It's quite easy in those cases
One more
because
thing I want to tell about difficult embryo transfer, which is very common these days, which majority people identify but don't correct. Okay, that is isthmocele. Okay, isthmocele is one thing which causes characteristic beautiful blood on outer catheter. Okay, correct the isthmocele if the patient is for fertility, because I think that is a very very important correction. If you see, but patient is not having pain, no problem, go and correct it. Okay, because correction of the istomosil itself will improve your fertility outcomes for that particular patient. That is something very important. I think these days very common.
Okay. Yeah. I think it was quite good. Thank you so much. There are not any more questions in the chat box. So thanks. I think you have a meeting. Thank you. Bye.